Hello and welcome everybody. This is Adam Hausman with Treace Medical. I appreciate everyone joining us here tonight for a discussion on our Nanoplasty 3D MIS Bunion Correction System. For those of you that are new to our webinars, we like to have these highly interactive. During the webinar, your lines will be muted. So if you have any questions at any time during the presentation or demonstration, please type them into the question chat box in your GoToWebinar control panel at the top right of your screen. We'll monitor questions as we go and answer them throughout the presentation. We'll also have some time at the end for those questions that may not have gotten addressed during the discussion. Tonight's session will be led by Dr. Brian Loder from Detroit, Michigan. Dr. Loder has been instrumental in not only the development of the nanoplasty system, but also in medical education training, including a course this past weekend. We are honored to have him leading tonight's discussion, and without further ado, I'll turn it over to Dr. Loder to get us underway.
Fantastic. Thanks, Adam. And thanks everyone for joining. I'm excited to share with everybody the Nanoplasty 3D MIS Bunion Correction and talk about how it makes your life easier without having to deal with the steep learning curve that a lot of us had to deal with at the beginning. And I think we did a great job at Treace creating a system that will allow you to get reproducible results early on after just a lab or two and presentation, understanding the instrumentation and the control that it does, and allow you to have a comfortable, predictable fixation device and correction. So let's get going. All right, this is me. Obviously, I can't see you and you can't see me, but this is who I am. All right, here is the statement that I am a consultant for Treace. These are my opinions that I have and I'm sharing with you. All right, so what are the goals for minimally invasive bunion surgery? I think we could work on the left side about it being about us, but I think it's really important for us to think about what are the goals for the patient side, because that is why minimally invasive hals valgus correction was created. It was created with the patient in mind. It was created to decrease pain, increase activity, allow early exercise and rapid return to weight bearing with less swelling. It was designed for improved cosmesis and better outcome. And patients on the market today with social media and advertising that's being done are looking for MIS surgeons. So in order, that population is causing the growth of what's on the left, and that is the surgeons. We are training more and more surgeons in MIS surgery than ever before. We would do these labs years ago with other companies and have sparse amount of people showing up, and even less producing the procedure within the weeks or months to follow, because the learning curve was too high, the instrumentation was difficult, and most of the time freehand was nearly impossible for the novice MIS surgeon. So what is it going to do for you? It is going to get you reproducible outcomes. The best benefit and what you want to happen is every nano and percuplasty patient that you operate on, the x-rays look exactly the same. You will have a hard time defining the patient by the x-rays alone. And therefore, we want reproducible outcomes. We also want an instrumented system that allows you to avoid the terrible learning curve like a lot of us had to come across in the early time of doing MIS. It allows you to address all the patient needs of 3D correction, allows you to get the IM in alignment, allows you to get the sesamoids in alignment and correct the DMA. And we all know the big focus on the sesamoid position and the distal metatarsal angle and the hals valgus angle are all important for us to reduce recurrence. And you'll get a high referral base. And the referral base is going to be from physicians. And trust me, you will have physicians in your hospital system asking you to do this on them, and they will be referring patients to you for life. And the other thing is that if you haven't experienced it, the open procedure, not many patients came back for the contralateral side. There is a high correlation with patients who have bilateral bunions having one side done, MIS, and coming back for the contralateral side. And you will experience that when you start to use the system, when you start to trust the system, and when you catch on to MIS. So at the beginning, MIS surgery was not accepted. I was one of the few people back in 2017 in doing it, and I felt like a lunatic on stage when the faces of people looking at our x-rays, and it looks like a banana and it's shaped odd and it's not connected and it doesn't look like it's ever going to heal. And so there is nothing more exciting to me than people joining in so I don't look so crazy, or didn't look so crazy. And that's what's happening. It's now catching on. It has now been accepted by the American College of Foot and Ankle Surgeons. We talk about it all the time at the annual meeting. It's being accepted by the American Orthopedic Foot and Ankle Society. Just this year, they did an entire pre-conference on MIS correction. And it's hard to find a publication right now that is coming out that doesn't have some kind of MIS study in it, because everyone is starting to report the outcomes. Remember, this was only started back in 2017, so we're not even 10 years into the process. And 10-year marks are really where the data starts to mean something. So we're starting to see that data come across, and you can feel comfortable that the outcomes are reproducible, they're good, and they're going to be evidence-based and peer-reviewed. So why did Treace get into the game? Well, as we all know, Treace is based on the rotational correction of the sesamoids and perfect 3D alignment of the hallux and the first ray in order to get the best correction and sustain correction. And it's with this video on the left-hand side, which it shows the Lapiplasty rotation being performed, and then it shows the rotation that is performed in the capital fragment osteotomy. And it became a sudden light bulb to the Treace organization that we can do the same thing in 2 different levels, and we can catch all of the IM angles and all of the types of surgery for the first ray with our products. And so that's why they got into it. And we were happy to work with them on developing this protocol. And so we all know that in order to keep the hallux valgus deformity in check, we want to make sure we can restore the sesamoids and correct the hallux valgus angle. That gives us absolutely the best result. So what have been the challenges in MIS? I mean, I've seen them all. I started at the very beginning. I had to do freehand. I've watched the instrumentation come through. So I am not novice to this. I have been able to participate and help companies with kind of changing this in the direction. But one of the problems has always been instrumentation. At the beginning, there wasn't instrumentation, so we had to rely on freehand and manual correction, which is hard, and that's where the high learning curve comes in. There was difficult to hold rotation, translation, and DMA correction all with your hands while placing screws and wires in the appropriate direction. And what would happen is the surgeon would either make too many pokes of the wire through the lateral cortex, weakening the cortex, or forget about holding it, drive the wire in, and lose the correction before they get in. The implants themselves were also not very good at the very beginning. The IM implants were just shoved into a position into the metatarsal shaft, and they pretty much pulled the head into the place that the company thought it should be. There was no fancy jigs to correct rotation or alignment. And it was hard to hold that in position. The implants, IM plates, also created a metallic bunion because they were either too bulky or too distal on the metatarsal head. And then you had the screws. The screws and the wires for the percutaneous approach on the market at the very beginning were flimsy. They skived. They weren't self-drilling. They weren't self-cutting. There was no jigs associated with it, so the freehand was very difficult. And take all that into consideration, adoption was under a problem already. We would get surgeons into a lab, to train them, have hours of sitting down with them, and they could never reproduce the concept in the OR just by one lab. And we're seeing a complete opposite shift of that. We're seeing these instrumentation systems are allowing surgeons to leave the lab on day one and go do a case, because it's about the system, it's about the instrumentation. The hardware and the fixation is coming along for the ride, but the big magic is in the system and the jigs. So this is what I'm talking about. If you haven't seen it before and you haven't been on one of our lectures, if you haven't tried it, this is a nanoplasty. To the left is the jig. It is designed purposely to maintain correction while you can visualize the X-ray, visualize the entire correction on X-ray, so the jig is not bulky. It has a bunch of added benefits to it that allow you to work within the parameters of the incision without the jig getting in your way. And on the right-hand side is the finished product, a model of what it looks like to have the hallux valgus corrected and shifted with the plate in place. One thing I do want to define right now, and there'll be a lot of discussion about this in the future, but intermedullary plates are minimally invasive surgery. Don't let anyone tell you they're not. The percutaneous surgeons in your neighborhood will be like, well, that's not MIS. It is. The definition of minimally invasive surgery is a surgery done in the smallest amount of incision possible to get it done. This is the smallest incision needed, 1.5 centimeters, to get this plate in and insert these screws. It's not percutaneous, but it is minimally invasive. So you can adequately advertise this to your patients and it will be accepted. And there are a lot more individuals doing these intermedullary plates in the proper setting with great outcomes, and patients are accepting it. So let's talk about the nanoplastic jig system, because this is where the magic happens. This is what the jig was made for. First, let's go to the middle slide, because this is why this jig is most important. It has a narrow lateral profile that allows you to see the alignment of the first metatarsal with the capital fragment. This is extremely important. We did a lab this weekend in Detroit, my hometown. It went fantastic. We had a lot of great participants. But always the question is, why not make the jig ortholucent so I can see it on the x-ray? And the main reason that becomes a problem is the more ortholucent it is, the weaker it is, which means the thicker and bigger you need to make it, and the more cumbersome and the more it gets in your way. And ortholucent is never truly ortholucent. It always shadows or blocks. So instead of going that route, we created a thin line jig that you, on a lateral x-ray, you can see down the shaft. You know that it's aligned. You know it's aligned with the jig, and you're able to get an idea of where your screws are going, where the head is positioned, and that you're all in line. So if we go back to the left picture, you'll see that that's the nanoplastic jig holding the plate. You can be very comfortable that the plate is secured onto the jig with the holder rod, connection rod, so it won't fall off, it won't drop on the floor. There's some plates on the market that you have to hold the plate onto the inserter when you put it in. You don't have to do that with this. We have it all connected and tight. The first step always, and one of the most important, is this positioning control knob that allows you to put the plate in a stand-up position perpendicular to the long axis to your osteotomy to get the best secure and best fixation. So we control where the plate goes. So you control where the plate goes. We don't make a plate that you just shove in and it goes wherever we want it to go. We want you to control it, and you control how much you position it upright, how much you rotate the osteotomy, how much you translate it. This is all under your control, which it should be. You are the surgeon. Tied into this is obviously a adjustable translation knob that allows you to move the capital fragment over. And then you have targeted screw devices that allow you to put the screws in the metatarsal head and in the shaft in a 1.5 centimeter incision. So about 3/4 of the work is done through a 1.5 centimeter incision, and then a small stab incision for the last bicortical screw in the tail. It wouldn't be Treace if we didn't have some kind of sesamoid rotation device, and we have that for this jig. And it is really neat to watch it work, and I recommend that even if it looks like your sesamoids are in perfect position, put the jig on, rotate it a little bit, get to see how it works, and make sure that you don't leave the table without the sesamoids rectus underneath the first ray. In order to making the cut, because most MIS surgeons think a burr has to be used, but we created this for individuals who are not burr friendly, who don't feel comfortable, and therefore we have a cut guide. And that cut guide is also the way to measure your 1.5 centimeter incision, so you stay in the minimal amount of incision needed to perform this procedure. And then we have drill guides to put the screws in to protect the skin and protect the tissue. So this whole system has been made for you to personalize and reproducibly do 3D correction on your hallux valgus. So this is the plate. The plate continues to change based on our needs of strength and covering larger patients and correction. But the jig is where the magic is. The plate is where the magic stays. And so the plate holds everything into position once you get it there. So you feel comfortable as a surgeon, you put it into the position, and then the plate holds it there. So the plate has two converging screws in the head. They're locking screws within the plate. Because they're converging, we had to make one longer and one shorter so they don't bump each other out. The reason why they're converging is that allows us to make the footprint of the metatarsal fixation smaller, so you didn't get any prominence both dorsally or plantarly or distally in the metatarsal head. We then have an angled locking screw in the shaft, and that holds security of the osteotomy in the proximal portion. And then we have a 2.7 threaded bicortical tail screw. And you'll see in our future XL that's out and becoming available to you, there's even 2 screws in the tail if you feel your patient is bigger, a larger IM, a larger metatarsal, a larger patient with BMI that you want to control. We made this plate low profile. It is thin, and then it actually has kind of a tapered end when you insert it to allow it to go in easier. So Treace is all about steps, making it easy, democratizing the system, democratizing the steps, and they like to break it up into 4 steps. And so the first step is always, let's get the cut right and perfect. So creating this cut guide that allows you to align it with the long line of the first metatarsal so it's completely perpendicular will get you your best correction, your easiest correction. The more off you're off the perpendicular of this metatarsal, the harder it is to shift. So don't be one of those surgeons that say, I know how to work a saw. I'm just going to make the bone cut. I'm going to fall from the system. Stick with the system, stick what's worth. Even today, as much burr work as I have done, when I do a nanoplasty, I freehand nothing. I go ahead and use the system, I use the guide, I use everything in line because that's how it works the best. So the first cut you do is you make the osteotomy. Now this osteotomy should be a little bit more proximal than you think it should be to allow the plate to tuck behind the medial eminence. We don't want this to give a metallic bunion distally. We want to hide it. Now, 99 times out of 100, you will not need to resect the medial eminence. You're going to get 100% shift with this osteotomy, or pretty much 90% shift. And therefore, you will create a rectus ray and the prominence won't be an issue. There is a small percentage, you may have to shave it down on a very large head, but it's very rare. So just plan to tuck this jig proximal to the medial eminence so you can hide it. So once you insert it, once you insert the plate into position, you will then secure the plate to the metatarsal, and then secure the jig to the metatarsal, and then do your translation. Once your translation is corrected to where you want it, the exact percentage, and be careful about over translating because you can bust that medial cortex of the first metatarsal. You'll start to see that your head abuts against your second metatarsal, and if you continue to try to push it, that first metatarsal will be pulled immediately and you'll end up getting a fracture, so be careful. So once you correct translation, you'll just lock your plate into the jig with the proximal where the proximal bicortical screw goes, and then you will go ahead and do a rotation correction. Once you do a rotation correction, you will then correct DMA and then pin your head to the jig. At that point, it is drill and fill. Your hands free. You can let go of everything. You will not lose your correction. It will not change. You feel comfortable that what you have on the table is what you're going to get. Let's talk about position because this is so important. Most surgeons are not used to the alignment of how we want the foot and how we want the leg on the operating table. MIS surgery requires fluoroscopy through the entire procedure without having to lift the foot up, put it on the fluoroscopy, back the fluoroscopy up. So you're going to want to position your foot about 12 to 18 inches off the table so you can rotate your x-ray beam around the right position of the first metatarsal or the foot. If you want to bump it up to get it out of the way of the other foot, if you're leaving that straight, then go right ahead. Personally, I don't like the other foot in my way, so I bump it out with a knee holder, so I'm staring at only one foot, and I can have full access to that foot, both medial and laterally. So I sit during the surgery, and I'm a right-handed surgeon, so I always sit to the left of the patient, and I always work from the side. If you want to work from the front on the patient and put the jig on and work everything from the front like you do for normal surgery, then go ahead and put the fluoro to your right or left. Now, I will tell you, one of the main reasons why I sit is so I can operate the fluoroscopy pedal and my burr pedal at the same time. That doesn't come into play with the nanoplasty, but when you start advancing to other technologies that Treace is bringing out that are other minimally invasive approaches, you may want to be able to work both foot pedals at the same time, which is very difficult when you're standing. So if there's not, if position is important, then X-rays are even more important. So getting the right X-ray, getting the right position, getting the right view of the plate and the correction is so important. And one of the most ill-taken X-rays is the lateral imaging. The lateral imaging, it can be rotated and you can't really see how your plate is lined up. It looks like your osteotomy is plantar flexed and it becomes a problem. So your lateral X-ray should be just like this one on the picture. It should be a slight cascade where you can see the 5th metatarsal mostly, and then a little bit of the 4th metatarsal plantar cortex, and then the 1st, 2nd, and 3rd are stacked on each other. This is exactly how we want an X-ray every time. And you will see when you watch the video, and my recommendation is this: do not skip X-rays. Take them every time you do some kind of maneuver. You go ahead and pin, take it. You rotate, take it. You translate, take it. You correct the DMA, take it. And right when you fixate everything in position, you take it. Once you know and you've got a hands-free, you don't have to take it for every maneuver after that, but you will because you want to see how the screws are sitting. So if the lateral imaging is important, so is the AP, because the AP shows us how the sesamoids are sitting, and we want that perfect AP 15 degrees that show us a clear view of the TMT, and we want to know that that is sitting on the right plane. It also gives us a good image of where the plate is sitting medially. The actual jig has a perfect circle on it, so if you have a perfect X-ray and the jig is perfectly medial, that perfect circle will be visible, and that's how we tell you that you have great alignment of your plate. The more medial the plate, the more perfect alignment of the head, and also the more the screws will hit where we want them to go. We don't want to angle the plate dorsally or planarly because it changes our trajectory. So X-rays, extremely important. You will need to get in the habit of taking them multiple times. So protect yourself, lead yourself appropriately, protect you and your family. And one word of caution: a lot of times patients will come into the office, you get these beautiful lateral X-rays, the head is down, the plate's in alignment, then the patient comes for their first post-op and they take an X-ray, your staff takes an X-ray with a supinated foot, and the X-ray and the head looks all wonky. It looks like it's plantar flexed, it doesn't look like it's aligned, and you're wondering what happened. Before you get too concerned, take the patient back into the X-ray room and take a perfectly flat lateral. You will see that your alignment is exactly where you left it. It hasn't changed. Patients weight bear pretty early on this, so it's not going to be a plantar flexed metatarsal that occurs with weight bearing. It's going to be dorsal. So, and it looks plantar when you have an inverted foot X-ray. So be careful. So let's go through the actual cadaveric demonstration. This is a surgical approach. This is one of the most important parts, is drawing an axial line down the metatarsal, because it helps you to find the exact location of your guide wire that you're going to insert. We want to check it both on a lateral and then take a picture of where the plate is going to sit. The osteotomy is guided with this wire, and I make it perpendicular to the 2nd metatarsal, and in the center of the metatarsal, just proximal, a little bit proximal to the medial eminence. So our cut guide is labeled distal and proximal, and it's definitely biased distally to allow the plate to go in. If you stay within the parameters of this cut guide by marking each edge, this is perfectly your 1.5 centimeter incision. That's exactly the working space needed to perform this surgery. That is minimally invasive bunion correction. Your dissection is down to bone and full periosteum, including the wire, and you'll just do mild dissection both dorsally and planarly. When you rotate this guide into place, you'll see the arms are retracting the skin on both sides, so your saw will not cause any damage to soft tissue. On a lateral, you'll line this long arm of the cut guide up to the metatarsal and insert it along the line you created. Double check this to make sure it's sitting in position. You also can see on the cut guide that I can see both plantar and dorsal cortexes of the metatarsal, so I know that the cut is going to be through and through. We have one more pin to put in, and that's our rotation pin. and you'll see this little block of 4 choices. I usually choose this one, which is the medial proximal one. Recommend oscillating this into position, not piercing to the plantar cortex so we don't bind into sesamoids. And I also recommend pulling the EHL out of the way when you do it. So now we'll remove the center pin because we have to make our osteotomy. And we've given you a saw to create this. That is the perfect size and length of this osteotomy. It's in your set. Once you complete it, the capital fragment will rotate and you know you're complete. If you have to go back and angle a little bit to get the dorsal plantar cortex, go ahead and do that. We'll actually pull the proximal pin out at this point and the guide will come off. You can use a freer to prepare your canal a little bit, but most of the time you don't need to. The implant can be inserted directly down the metatarsal shaft most of the time. And that's what we're doing here. I'm going to jiggle that into position till it's completely medial, and then our control knob will go down. We'll kind of stand our plate up into the position you want. Now, you'll see that actually we get a lot of translation and rotation correction right away. And so already the alignment looks good. And that's why when we do our translation and rotation, we're just dialing into correction. So once we check an AP and a lateral, we're going to pin the jig to the foot on these. There's 4 options on the control knob base, and we'll just pin it into position. After we pin, we'll check again an AP and lateral. Again, maneuver, check, maneuver, check, maneuver, check. Get in the habit of that. Once our jig is pinned into position, we'll go ahead and translate the head for any correction we need to. We want to get it to about a 90 to 100% correction every time. Don't over tighten, just 2-finger tightness to get it in position. If you want, do it under fluoroscopy. This is where we check an AP and lateral again. You see those 2 screws in the metatarsal head, how they're visible, what we call the Mickey Mouse ears. Once we have this down, we'll put our tail tack in. That will actually hold our plate in position. Now our plate is secure, so it won't distally migrate with our manipulations. We're going to put our control rake on right now, and it's going to go right on the jig. The control rake has multiple places to hook your pin up to, because if you happen to have a plantar flexed osteotomy, you just have to rotate the pin proximally on that jig and you'll get correction. So you see the sesamoids are rotating into position, and we can pick exactly and dial in our correction. Isn't it wonderful that we're allowing you to pick where your metatarsal and sesamoids go, and we're not dictating that to you? We're just creating the system to allow you to do that. So here's the maneuver that allows you to either plantar flex the head or dorsiflex it, depending on how to get perfect alignment. We want it rectus, so you won't be purposely plantar flexing or dorsiflexing, you'll be correcting. Then your last maneuver is to pull the toe towards the jig like you're applying a bike brake, and then you'll pin the jig to the capital fragment. Once you pin the jig to the capital fragment, you are hands-free. Your position is bought, so make sure you check x-rays prior to doing this or right after you do it. You can always back these pins off, reposition your DMA, re-rotate your sesamoids, retranslate. Nothing is fixed at that point, and then you can place your wires back in. We're going to go ahead and take our rotation guide off because we have bought our correction, and then we're going to go ahead and put our head screws in. We have a screw guide that goes over the post that you can see right on the jig, and they're labeled plantar and dorsal. We're going to go ahead and drill fully down to a stop the dorsal, and then pull the drill out and drill the plantar and leave it in. This is another safe amount of fixation to allow you to crank your screw down on the locking plate and make sure nothing rotates. These are locking screws, so don't fall short of seating them. You'll take out your plantar pin drill guide and you'll insert your screws. So your 2 screws are going to be 10 millimeter and 18 millimeter, and they are fixed. And so you'll have the same screws every time. You'll take out your drill guide. Now the next screw is going to be our angled screw hole selection, and you have 2 choices. You can do a distal or a proximal. I will tell you about 90% of the time, if your plate is standing up in the right position, you will pick the proximal angled screw hole. And so when you drill this, you want to drill through the lateral cortex, and you want to plan the appropriate size and we have 10, 14, and 18 measurements here for your screws, you want your proper size of those three options in order to get at least 2 to 3 screw threads across the lateral cortex. So you'll go ahead and drill and look at it under fluoro and see where you line up on that drill guide for either 10, 14, or 18. And so this appears to be a 14, the way it was measured. So you will actually pull out the drill and you will actually insert the appropriate 14 millimeter screw. One of the big mistakes here is not seating the screw. So if you have trouble seating the screw, let your rep get you a low profile screwdriver to seat it better. But its strength is gained by that screw being tight against the plate and 2 to 3 threads across the cortex. You'll pull out your tail tack and you'll put your last piece of hardware in, and that is your tail tack bicortical screw. And you'll measure that. Our new systems have a measuring device that will actually allow you to measure it under X-ray to get the exact length of that screw. And then we provide you with 3 lengths in your set in order to insert the appropriate screw that you have. So once you get that screw in place and it go down to the cortex, you're fully fixated. You can take all your wires out. You can unwind your correction of your translation, back off your connection rod, and back off your control rod, your control knob, and then your jig will come right off the plate. And there's your correction through a 1.5 centimeter incision. And you can see on X-ray that the plate is standing up securely aligned on the lateral and AP view, and perfect correction. Now, every MIS procedure leaves a spike behind. Some of the old companies out there would just leave that. Their plates were not designed to allow the medial spike to be removed. We always remove it. That way you narrow the foot. So you have 2 options to remove that. You can remove that with a rongeur, or you can remove it with a burr. It's hard to put a saw in there. It's fairly dangerous to the tissues. So if you're burr friendly, you can use a burr. If not, I recommend using a rongeur, and then you can use the NanoRasp, which is a new product on the market, to grind down the remaining spike that's there. I would not use it on the fresh cortical bone there because it'll generate some heat. You would have to continue washing it out. I want you to remove part of that spike with a rongeur and get the rest with the NanoRasp. Once you get comfortable with the NanoRasp, it works fairly well for MPJ fusions or tarsal fusions or tarsal metatarsal fusions. So it's a good tool to feel comfortable with when you want to work in a small parameter. So 99% of the time we do an Aiken when we do a minimally invasive bunion. So, and the only time we don't do an Aiken is when we wish we did do an Aiken. But the small 1% is because they're really young population. They have a flexible deformity. The first ray goes into perfect rectus position, and we don't have any snapback or valgus deformity. But you will get in the habit of always doing an Aiken. Now, there's 2 opportunities to do that. There's 2 ways to do that. You can do that with a speed Aiken compression implant, or you can do it percutaneous. My advice to you is get comfortable with the burr at some point. Patients are looking for that. They're looking for minimally invasive surgeons to do other stuff like DMMOs and hammer toes and percutaneous bumps. And so I want you to be comfortable with that. So try to cut your teeth on the burr usage with the Aiken. And so if you do a burr osteotomy, then you can correct it with one of our beveled screws that the percuplastic technique has. So keep that in mind. So this is some examples of cases and what it looks like on the healing progression. We always get the question, does that really heal? Yes, it does. Our non-union rates for how MIS bunion corrections are so small, probably the smallest of any bunion correction on the market. I mean, we have our design team talks about this all the time, and between us, we have about 6,000 cases between all of us. And I think we're lucky if we have 10 to 12 non-unions out of all those cases. So it's very, very rare. And so you can feel comfortable that this shift produces results and it does heal with any kind of modality of post-op recovery you want. It is strong. Just be careful about patients with poor bone stock or weak bone. You want to protect them. So you'll see 6, 9 months, 12 months later, depending on you see your post-op, you'll see that whole triangle of lack of bone at that lateral cortex filled in and the ray being rectus. So it will happen to you. So what is your post-op protocol? Well, my post-op protocol is a little different than others, but you can follow whatever you want. I start weight bearing in a surgical shoe immediately after surgery. I ask them to weight bear on the heel for the first 24 hours while they're numb, and then I advance them to full flat weight bearing. I will move them out of the surgical shoe at week 5, and I'll start them with a tennis shoe. I have them put the tennis shoe on, I preferably laces so they can tighten it down, squeeze out some of the swelling, and therefore they can start increasing their activity. I allow my patients to go to biking, to walking not on an incline, to elliptical, to swimming, to rowing after 6 weeks, and I only high impact activity of running and jumping at 3 to 4 months. There are other individuals that feel more comfortable putting patients in a cam boot, which I have nothing against. Just keep in mind, if the ankle is not plantar flexing or dorsiflexion, the natural soleus pump is not working. So there can be a little bit more edema collection on patients that are in a cam boot. So we now have a little bit larger plate. It's 4 millimeters longer than the regular nanoplasty, and it's called the Nanoplasty XL. And it allows you to have 2 points of fixation at the tail, which gives you a little bit more security in the larger patient. And also, because it's 4 millimeters distal, if you don't want to put the more distal screw tail tack in, that'll give you a little bit more medial eminence to resect. So it allows a little bit more shaving of the bump off medially, so you don't run into your bicortical screw. They are offset, these 2 screws, so they're stronger because they're offset from all the other fixation. So it allows to give better strength in that larger patient or that patient with a little bit more poorer bone stock. Even in situations of bone stock, I would protect poor bone stock. I would protect them in a cam boot. It's just safer. After about 4 weeks, the bone will heal enough for make them weight bearing, but it helps to protect that poor bone stock patient. They're like those individuals, those females over the age of 60. We like to protect them a little bit more. So this is what the nano incision looks like. This is what it looks like with the plate in position. This is the procedure. I know you can do it. I know it's reproducible. This Treace has set up this jig for you to win, for you to enter the MIS market. And at this point, I'm happy to take any questions, if there are any, to answer any concerns or questions that individuals have.
And thanks, Dr. Loder, once again for another fantastic presentation. As Dr. Loder shared, we've got kind of open time for questions. Feel free to share those on the kind of control panel on the right-hand side of your screen. We did have our first question come in, Dr. Loder. Is there a maximum IM angle that you can perform this procedure on?
There is, I mean, really, really large IMs. You can't get this osteotomy greater than 100% correction. You know, and in order for the plate to be in contact with the head, it's got to be about a 90%. So, and I think the nanoplasty is the perfect procedure for that 11 to 14 range. And anything larger than that, if you're comfortable with percuplasty, that'll fill that gap. If not, the Lapiplasty is the best option in that situation. And if you're comfortable, the Lapiplasty has been out for years. The equipment is top notch. The instrumentation is getting smaller and smaller. It's almost pretty much a minimally invasive surgery anyway. And so it's a great option on those IM angles above 14. But I would probably limit yourself from about 11 to 14. And that is the deformity of the IM angle. Any hals valgus angle can be correctable. So the hals valgus angle is all about controlling both the great toe and the first metatarsal head.
Can you speak, Dr. Loder, to when a distal lateral release might be appropriate, and when during the procedure would you choose to perform that?
So unlike other procedures, when you do the lateral release at the beginning, in order to allow your head to rotate or position, we don't need to do that. We're moving everything in that joint as a function of one. So if we're going to do a lateral release, it's only going to be done if there's a small amount of snapback of the toe against the second toe. If the toe is not sitting straight and off the second toe when you've done your Aiken and when you've done your osteotomy and secured your med head. And the only time you want to do it is then. And one of the reasons you don't want to do it early, and this is really important, one of the reasons you don't want to do it early is because your final correction of your metatarsal head is correcting your distal metatarsal angle. And in order to correct your distal metatarsal angle, you have to pull the toe over medially, and the med head should follow. If you release the capsule and the ligaments laterally, the med head won't follow. And so you will lose your ability to control your correction of your distal metatarsal angle. So it's going to be done rarely, and it's going to be done last.
Well, what about possible utilization of a tourniquet? Is that part of your kind of setup protocol?
So I do not use a tourniquet at all. I like to be able to bathe my burr, my saw in the natural cooling mechanism of the body. I also found that not using a tourniquet lowers the post-op pain. These are small little pokes. You get small little compartment syndromes at each incision site that can be somewhat painful. I found an easy way to control bleeding is to just Trendelenburg the foot 30 degrees. We used to have a bloodbath at times doing these procedures in the normal flat position. And then when we started putting them at a 30-degree Trendelenburg, we had minimal to none. So feel comfortable that this procedure and all MIS procedures in general can be done without a tourniquet. And it has changed my approach to foot surgery in general. I very rarely use a tourniquet even for reconstructive cases anymore. We're so comfortable with the small amount of bleeding and the good dissection. So you don't need a tourniquet. Just set yourself up in the environment to minimize blood loss.
How about implant removal if necessary? Do you anticipate that that would be a challenge?
No, I don't think it's a challenge. What makes it a challenge is if you bury the bicortical screw. So you want to create that bicortical screw so it's sitting just at the level of the cortex. Don't bury it. Otherwise, when you do your medial spike resection, you're really opening up the internal contents of that plate for you to get all those screws out with that 1.5 centimeter incision. So if you have to remove it, you find your bicortical screw, you remove that under a cannulated environment, and then you make your 1.5 centimeter incision, backing out your head screws and your angled screw. And then what you'll do is just take a very thin chisel, the thinnest you have in your set, and you'll just tap it down the medial cortex of the shaft that's remaining, and tap it down behind the implant, down the center of the shaft, and then this implant will come right out. You won't have to remove many. It is not going to be palpable. The most time you're going to have to remove it is when a patient just absolutely doesn't want to have any metal in their foot. And that's a good conversation to have with the patient at the beginning when you make this decision. So you may want to leave your bicortical screw a little proud so it's easier to get out. That's always good for them for you to ask them, is it okay to keep the metal in? Are you planning on taking it out? So you can adjust your approach.
We had another question come in asking for any tips on plate position during insertion in the metatarsal shaft, specifically on the AP from a medial lateral standpoint.
Yeah, I would ask you, the best correction you'll get is if you guide your plate to as lateral as possible to get it. And so if you want to insert your freer in, you come at an angle to course along the lateral wall of the metatarsal, and then your plate will actually just guide into that position, into where you kind of created a line for it. The more lateral you are, the less your two screws in the shaft will come close to each other, and the larger amount of bridge between your angled screw and your osteotomy. So I always prefer my plate standing up as much as possible, to stand up almost perpendicular to my osteotomy. That gives it its best strength. That makes sure that the screws are angled to in the distal head and away from my osteotomy. I just like to stand that plate up. So I use the control knob to dial my plate into position. That's one of the most important things I do. And then I check the lateral to make sure that it's in perfect lateral alignment. And those two things is how I guide how my correction is going to stand.
You showed a slide, Dr. Loder, on both the speed Aiken as well as the perk screws for Aiken osteotomy fixation. What are your preferences amongst those options?
Yeah, like I said, I'm an MIS surgeon. I want there to be MIS surgeons. I like the speed Aiken approach. The problem is there's an incision there that almost bridges those two incisions so close. At some point, the patient will think that they're just one. So I really encourage physicians to cut their teeth on the Aiken. Learn how to do a proper Aiken, learn how to use the burr, learn how to control it, get that comfortableness in your hand. It'll allow you to throw the percutaneous screw into the base of the proximal phalanx, get comfortable with that angle, the alignment, and then the world will open to you on MIS surgery. You'll get into osteotomies of the fifth, you'll get into lesser osteotomies, and you'll start to feel comfortable. And the minute MIS world opens up to you, the minute patients will start pouring in for your consults.
Any concerns, Dr. Loder, about standing the plate up too much and point loading on the medial cortex with that proximal tip?
Yeah, you don't want to overstand it. Absolutely not. You don't want to go too far, because on top of that, what it does is it drives your distal screws too close to your osteotomy. So you got to be careful about that also. So you want it standing up in the metatarsal, aligning your metatarsal head, snug against your metatarsal head, but and closely parallel to the second, but not completely. You're right about that.
How about situations where you may see a failed lapidus? Is nano kind of viable as a revision procedure, and does that necessitate any removal of the pre-existing hardware?
So good question, Adam. So the as long as the hardware doesn't broach the distance where our bicortical screw is, which most of the time it doesn't. So I love the nanoplasty for failed repair of lapidus procedures. I love it because I'm able to put it in. Now, if the patient has no metal irritation, I am not making an incision to take that metal out. I leave it in the lapidus procedure. The other benefit is, in order to put the percuplasty or screws in, you have to crank the proximal metatarsal medially to get those screws at the right angle. There's no motion at the TMT anymore. That's harder to do. So the nanoplasty almost perfectly works for reconstruction of a failed lapidus procedure. It is my instrument of choice for correcting those.
Okay, we've got another one. Do you find shortening to be a issue or consideration of the first ray with large IMs in particular?
That's a great question. It's funny, with Austins and scarfs, elevated lapidus procedures that were malaligned, metatarsalgia is a killer. But we have shortened the metatarsal in the MIS world 2 millimeters, because that's the size of our burr, and we don't see metatarsalgia. And it's not because it's the shortening, it's because the functionality of the metatarsal phalangeal joint is not violated. So it's still rotational, it's still congruent, it's still dorsiflexing. So the patient doesn't need to transfer the weight over. It still propels off of the rectus first metatarsal. So take the number of cases I have, which are very large. I treat almost none post-op metatarsalgia at all, and feel comfortable that the shortening you get, one, is tolerated, but number two, it decompresses the joint a little bit. So what we also find is that normally if a patient is type 2 in an arthritic condition, we're refusing that joint no matter what in the presence of a hallux valgus. But because we decompress by 2 millimeters, we're taking some pressure off that first MPJ, and patients can tolerate the hallux valgus correction without fusion much easier with an MIS procedure.
Appreciate that, and it appears to be all of the questions we've received in the chat box at the moment. I'd like to thank you, Dr. Loder, for another excellent presentation, and appreciation for all the attendees for their interaction and engagement throughout the session. For those of you that do have interest in exploring cadaveric training on this procedure, we do have an abundance of upcoming training opportunities, so please contact your local Treace rep, and they'd be happy to explore registering you for one of those upcoming events. Again, thanks for all attendees joining us tonight. Have a great rest of your evening.
Thank you very much, guys.